Now let's see the clinical anatomy concerned with the brachial plexus. I recommend all of you to see the anatomy of the brachial plexus before viewing this video. So first and most important palsy concerned with the brachial plexus is the Erb's palsy. This Erb's palsy, it occurs because of the injury to the upper trunk of the brachial plexus. So the nerve roots involved within this Erb's palsy, they are the C5 and C6 nerve roots. The symptoms we can see in this Erb's palsy is shown in this figure, and we can appreciate that in this Erb's palsy the forearm is extended and pronated. The shoulder joint is medially rotated and adducted. So this symptoms gives rise to the Erb's palsy. It is also called as the policeman's stiff hand, or it is also called as the waiter's stiff hand palsy or the porter's hand palsy. So the other three names of the Erb's palsy are the policeman's stiff palsy, porter's hand palsy, or the waiter's stiff palsy. Because of the appearance of the uh, bribe taken by the policeman or the waiter, that's palsy. It is also named as a policeman's tip or the waiter's tip palsy or the porter's hand palsy. Here, let's see the Erb's point where we have already discussed in our brachial plexus lecture. So C5 and the C6 root both are going to fuse and form the upper trunk, and this upper trunk, it will divide into one anterior division and one posterior division. And before going into divide into anterior and the posterior division, the upper trunk gives two branches. One is the suprascapular branch and one is the nerve to the subclavius. So these six branches are affected during the Erb's palsy, and when the injury to this upper trunk at this particular point is called as the Erb's point. So the six nerves are going to be involved in the Erb's point, and these are the C5 root, C6 root, suprascapular nerve, nerve to subclavius, anterior division and posterior division of upper trunk. So these are the six branches are involved in the Erb's palsy. Now let's see how this Erb's palsy is going to be occur. This Erb's palsy is usually the reason behind this Erb's palsy are when the patient fall from the height on his shoulder, that will lead to the hyper separation of the head and the shoulder, and that is one of the reason behind the Erb's palsy. So upper trunk gets stretched, and this stretching of the upper trunk will lead to the injury of the upper trunk. The second cause is during the delivery of the baby, when the clinician uh, deliver the baby with the help of the forceps or with the hand. At that time, the hyperseparation of the head and the shoulder may also lead to the Erb's palsy. So these are the two reasons behind the Erb's palsy. Now let's see the clinical correlation of the Erb's palsy with the symptom. So when we have seen that in the Erb's palsy, the shoulder joint is adducted and medially rotated. The axillary nerve having root value of C5 and C6, when the injury to this Erb's point, that will lead to the affection of the axillary nerve, and with the affection of the axillary nerve, the deltoid muscle get paralyzed, and with the affection of the deltoid muscle, the shoulder joint abduction is affected, and that's why the adducted shoulder joint is the symptom. The musculocutaneous nerve is having the root value of C5 and C6 roots. When injury to the musculocutaneous nerve, it will affect the biceps brachii and the brachialis muscle. So the paralysis of the biceps brachii, it will lead to the loss of the supination movement, and that will lead to the pronation of the forearm. While the injury to the brachialis and biceps brachii both will affect the flexion of the forearm, and that is the reason why the forearm is in the form of the extension. The injury to the suprascapular nerve will lead to the paralysis of the infraspinatus, supraspinatus, as well as the injury to the axillary nerve will lead to the paralysis of the teres minor muscle also. So the teres minor and the infraspinatus both are typically responsible for the lateral rotation of the shoulder joint, but when the paralysis of these muscles occur, it will lead to the medially rotated shoulder joint. So this is the explanation why the symptoms of the Erb's palsy occur. So this is a very important clinical anatomy concerned with the brachial plexus, where you have to remember this is going to be occur by the injury to the upper trunk. And the palsy, it is called as the policeman's tips palsy, or it is also called as waiter's tip palsy, or the porter's hand palsy. So there are different names of this palsy, and in examination you can be asked with the any name of this palsy. Now let's move on to the second important palsy of the brachial plexus, and that is called as a Klumpke's palsy. This Klumpke's palsy is occur because of the injury to the lower trunk of the brachial plexus. So the roots involved with the lower trunk of the brachial plexus are C8 and T1. So most of the time the Klumpke's palsy occur because of the hyperabduction of the shoulder joint, but during the fall from the height. If when the patient fall from the height, he or she try to hold the things which comes in the way, and at that time it will lead to the hyperabduction of the shoulder joint, and this hyperabduction is the main cause behind this Klumpke's palsy because of the injury to the lower trunk of the brachial plexus. The symptoms concerned with the Klumpke's palsy is the claw hand, because C8 and T1 roots, they are responsible for providing the nerve supply to the intrinsic muscles of the hand, and when the paralysis of these intrinsic muscles of the hand occur, it will lead to the hyperextension of the metacarpophalangeal joint and the flexion of the interphalangeal joint occur, and that will give rise to the symptom of the claw hand. One more symptom concerned with this Klumpke's palsy is the Horner syndrome, or we can say this Klumpke's palsy is usually associated with the Horner syndrome. This Horner syndrome occurs because of the affection of the T1 root, and this T1 root carries the sympathetic fibers within it. So sympathetic fibers of the T1 root, when get affected, it will lead to the cluster of the symptoms, and that is called as a Horner syndrome, which include the partial ptosis. The eyelid of the patient, it is dropping down, and this is the partial ptosis with the Horner syndrome. The Horner syndrome also having the symptom of the meiosis, when the constriction of the pupil is there. The third symptom with the Horner syndrome is the anhidrosis, and that is the loss of the perspiration on the affected side. So the sweating is not there with the affected side. And the fourth symptom concerned with the Horner syndrome is the anophthalmos, where we can see that the eyeball looks shrunken and it is situated deeply inside the eyeball. And that is called as the anophthalmos. So these are the symptoms of the Horner syndrome. So the Klumpke's palsy is also one of the important clinical anatomy concerned with the lower trunk of the brachial plexus. So this Erb's palsy and the Klumpke's palsies, they are the frequently asked clinical anatomy in the upper limb topic. So hope you understand well. Thanks for watching.